I think it is 8:05. So I will take this off for a moment and get ready. I think we are already Zooming. I just found out via the mini text I received. Welcome to Grand Rounds, November 12th. I am Laura Youngblood. I'd like to introduce Dr. Eric McCart as our speaker for today. Dr. McCart attended medical school at the University of Tennessee Health Science Center in Memphis. He then went on to complete his internal medicine residency training at the Medical College of Virginia in Richmond. In 2015, Dr. McCart relocated to Chattanooga, Tennessee, where he started as a hospitalist at the Erlanger Health System. And then to our delight, he joined us in 2019 on the academic side as an affiliated assistant professor in the Department of Internal Medicine at the University of Tennessee College of Medicine, Chattanooga, where he's an academic hospitalist within the Erlanger Health System. Dr. McCart's topic today is one of great interest, especially in this time, the color of medicine and how race impacts healthcare in America. I do applaud him for taking on this topic. I think that if we have a lot to gain and learn and change our future, that we must understand our past. So with that, I will give it over to Dr. McCart.
All right, thank you. So today we're going to talk about race. My topic is the color of medicine. My name is Dr. McCart, for who don't know me. You can't hear me? All right. Can we hear me now? There we are. So you don't have to adjust your settings on your Zoom. I'm here as one of the wisest people in the room to talk about race and talk about medicine. So I'd like to address the elephant in the room starting out that is in fact the case. Before doing this research for this talk, I admit I didn't know a whole lot about the topic. Never felt I really had to. But in light of the news, recent onslaught of shining the lights on the social injustice in this country over the last year, I felt compelled to educate myself on what was going on and thought that this talk and this Grand Rounds offered an opportunity to discuss this information. Because what I saw was that I didn't see that what was talked about was that institutional racism affected the society as a whole, but also that healthcare was one of those institutions and how race can affect that institution itself. And so I thought this was an important topic to talk about for that reason. So the limitations of me talking about this topic in particular, obviously that I'm coming at this topic without any real lived experience. I certainly have heard the stories of my friends or family and loved ones tell about their lived experiences, and it's heartbreaking, but hearing a story and living that experience hardly compare. So although I've not seen or I've not experienced that racism, what I have as a provider seen clearly the divide that occurs and exists on long racial lines in healthcare, whether we're talking about outcomes, levels of physician distrust, medical access, or even the benefit of the doubt given to patients when discussing medical compliance. What I've witnessed is providers be quicker to doubt the sincerity of patients of color when they complain about pain, see non-English speaking patients get the looks good from the doorway treatment because it took too long to get the translator into that room. And of course, the phrase that I've heard, oh, it's just another sickler looking for pain meds when referring to an acute sickle cell pain crisis. That's not everywhere. It's not descriptive of our providers. I'm very proud of the providers we have here, the work Erlanger does, and their efforts to treat everyone that comes through the door, regardless of other factors in this region. The diverse patient population we have here, as well as the indigent care we provide at this hospital to this region, is one of the biggest reasons I came here. But I doubt if you're listening to this and you're honest with yourself, that you would deny having ever heard any one of those phrases uttered in your career or in your training. So today what I'd like to talk about is identifying the forms of racism and how it affects healthcare, reviewing historical experiences of communities of color in the American health system, examining continuous effects of race in healthcare, and address opportunities for change for more equitable healthcare outcomes. So I think we have to start this conversation with definitions so we can all speak the same language when we're using to describe this, to have a basic understanding of it, and to be better able to communicate and recognize it. Racism simply isn't, if you hold a tiki torch and you yell racist slurs, that constitutes the entire spectrum of racism, and that's not it. And if you don't participate in that, then you are no way associated with or contributing to anything involved with racism. So those are obvious actions. We all recognize them. They're explicitly racist. But they're just one small part of the different levels and forms that racism takes. And that's one of the reasons why it's so difficult to grasp, to talk about, and describe or fully understand. And particularly like me, if you've never really been on the receiving end of it, which I haven't. I spent over a year in countries where I was absolutely a minority, the countries, and no one around me for hundreds of miles looked like me. But never did I really experience racism. And it wasn't because those racism didn't exist in that country, because it certainly did. It just was never aimed at me as a white man. So the topics and the way and the levels that I'd like to talk about, on the first level would be individual level racism, in particular explicit versus implicit bias. Then next, talking about institutional racism, and then finally internalized racism. So on the individual level, what you have is prejudice or discrimination based on the race. Prejudice being your assumptions made about a person or group of people's ability, motivation, or character, or intention because of their race or appearance. Discrimination will be acting on those prejudices by treating the people differently because of that race. And these can be actions, they can be acts of omission. On actions, they can be suspicions. Someone, a shopkeeper's security guard following people in a store, someone clutching their purse when a person of color enters the elevator, or crossing the street when someone's walking near you that doesn't look like you. Additionally, you have dehumanization, hate crimes, brutality, weaponizing family separation. In the terms of acts of omission, what you can see is lack of respect, poor or lack of service, limiting options given to people based on their appearance or their race. This is one that we particularly see in healthcare that we'll talk about later. And then you have devaluation. You have surprise at competence. If you've ever heard the phrase, "Oh wow, you speak really well," or "Oh wow, you're very eloquent." You have suppressions of aspirations or stifling of dreams. And it's particularly dreams that are stifled because the expectation that the expressed goal is unachievable due to their race. Individual racism, you divide it, and the examples that you see are from either explicit biases or implicit biases, with explicit ones being preferences or beliefs and attitudes with conscious awareness. If the person would admit it, they'd be able to identify and communicate those biases with you. You know, I believe group X is more likely to steal. Implicit bias is the harder one to define and to identify. It's unconscious. The associations and reactions that emerge reflexively without awareness, and they give rise to unintentional actions. The person doing it doesn't know they're doing it. And what an example of this would be is you don't know it's there. Most of us don't think about it. We don't think we have implicit biases, but we do. If I were to say right now, downtown Chattanooga, there's someone who is dangerous, violent criminal walking downtown, and you close your eyes and try to visualize who that is that person blonde-haired and blue-eyed? It probably wasn't. And that's an example of implicit bias. I didn't tell you anything about the person except that they were violent and dangerous, not a single descriptor of what they look like. Your mind automatically started to build a visual in your head of what they look like based on years of input from the time that you could remember, from TV, from shows, cops, movies, late night news, all contributed to what you see in your head when I say those words. You didn't make that conscious decision. The implicit bias goes unnoticed by the person committing it, but can have real-world consequences to black and brown people to some degree. And it's less a reflection of ourselves and more of the environment we inhabit and inputs we receive. Much of it you have no control over. On the institutional level, this is differing access to the goods, services, and opportunities in society based on race. They're normative, manifesting as inherited disadvantages. And they're integrated into our structures, into our many institutions, including healthcare. And they're evident often as inaction in the face of need. Internalized racism was one I really didn't know a whole lot about starting out. I wasn't as familiar with and hadn't recognized it. And this is the acceptance by members of the stigmatized race of negative messages about themselves and their intrinsic self-worth, accepting limitations of your own ability, self-stifled dreams, aspirations due to message internalization, and self-devaluation, resignation, and hopelessness is what can occur. Much of what I learned about the different levels of racism I got from an article by Cameron Phyllis Jones, a Harvard fellow, and former CDC research director on social determinants of health. And so I use that one, so I'm going to steal it here and use it. Hopefully it helps you as well, much as it helped me. So Gardner wishes to plant flowers in front of her house. She wants to plant red flowers and pink flowers. She sets up two flower boxes. One already had dirt in it. It was old, rocky dirt. The other one was empty. So she filled it with new soil. She prefers red flowers, so she put the red seeds in the new, rich soil while putting in the pink flowers in the old, rocky soil. That spring, when the flowers grew, the red flowers came in full and luscious. However, the pink flowers in the old soil came in with smaller blossoms and less impressive. And year after year, those red flowers dropped their seeds into the rich soil in their box, while the pink flowers continuously dropped their seeds into the older, rockier soil. And each year, the red flower blooms were fuller and more vibrant than the pink ones in the old soil. As bees came to pollinate, the pink flowers saw this difference too. They told the bees, "Don't pollinate me with the pink pollen. I only really want the red flower pollen. They are obviously the fitter flower." As years passed, the gardener had long forgotten at the beginning that there was any difference in the two soils. She looked over her two flower beds, one with full red flowers and one with smaller, less impressive pink ones, and said, "See, I was right to prefer the red ones. Look how full, how vibrant the red ones are, and how small the pink ones have grown." She's attributing all the differences between the two flowers to the flower itself, and none to the different soils in which the flower grew. The soil in this story is representing institutional racism, preventing the full growth of the pink flowers in the poorer soil from reaching the full potential at a higher rate in the new soil, compared to the new soil that the red flowers have. Differing access to education, housing, redlining, easing of obtaining and advancing in employment, discrimination in criminal justice system, and of course healthcare, that's our soil. The institutions that can affect and nourish or stymie and impede growth. Internalized racism is visualized in the acceptance of the pink flower, that the fitter flower, the inherently better flower, everything about it is the red flower, and thus preferring pollinizing with the red flower. So, do we actually know that people of color have different outcomes in healthcare? Is this something we should actually be looking at and worrying about? In 2015, the CDC released a report on racial and ethnic health disparities and put out statistics showing that there were significant differences, particularly in Black and Latino communities, compared to whites, particularly in childhood obesity, life expectancy, infant mortality, preterm birth, and hypertension. So going over some of that data, here we have life expectancy. What you can see is that the average life expectancy in America in 2014 was 76.4 years, while the average life expectancy, and that was for a male, and for the average life expectancy for a Black male was 72 years. It might not seem like a huge difference, but that average for a Black male puts them just behind Bulgaria, the country 90th best in the world for life expectancy. Here we have infant mortality. And as you can see, Black and indigenous people have suffered disproportionately with infant mortality rates, but Black children suffer the worst, having over 3 times as high risk for infant mortality than the lowest risk groups. Obesity is one that is affecting us more and more every year, and significantly overrepresented in the Hispanic and Black communities. As you can see on the bars on the left, representing the total average percentage of childhood obesity, Black and Hispanic children are much higher risk of this than the average in white or Asian children, coming in at 21.9% in Hispanic patients versus 8.6% in Asian, or 14% in white patients. For hypertension, overwhelmingly affecting Black Americans. For women, as you can see on the right there, 44% with hypertension compared to just 28 or 25% in Asian and white patients, or 20% percentage points different in the two of those, and that's unacceptable. There's a lot of factors for that, but that certainly is a jarring factor considering what hypertension can lead to and its end organ effects. Vaccination in the African American and Hispanic populations are far lower as a marker for preventative screening. And they have the lowest rates of vaccinations against the flu in particular, as this graph shows. And there's some obvious cultural and historical context in which we see these racial divides for vaccination results. And here we have insurance records or insurance coverage. In this country, insurance is a major determinant of access to medical care. Black and Latino populations lag far behind white Americans in insurance access. And all access obviously has improved after 2015 with the Affordable Care Act, but I imagine if that was expanded out, that trends have probably gone in the wrong other direction in the last few years. Now, these graphs and data obviously don't explain the why, but certainly paint a picture that these outcomes aren't equitable. And it's an immensely complex topic as to why. I don't pretend to understand all of it, but I was hoping with this topic that we could start to dive deeper into it and start this conversation about why it occurs and what role we as providers might play with this. And I think another thing we have to do to understand where we are now is understand where we've been in this country with race and how they've interfaced with the healthcare system. Because we don't live in a bubble and don't exist in a bubble, and how we have and our patients have viewed healthcare wasn't created in a bubble, and the burdens of the past have affected how we are viewed at this time right now. And so what I think will help is to take, and it helped me, was to take a deep dive in historically into how we've gotten here from where we've been. So I'm going to have to take it all the way back. And so from the beginning, starting at the beginning, doctors in this area, particularly in the South, were intimately involved with slavery. We participated in evaluations of slaves being sold. We're paid to ensure the health and fitness of slaves. And we're obviously focused less on the well-being of those people versus the financial soundness of the purchase on behalf of the slave owner. Additionally, physicians in this area were routinely called to evaluate sick slaves on plantations. Unfortunately, these assessments were so often dissolved into accusations of malingering and perpetuating stereotypes. And callous treatment recommendations often followed, as can be described as 9 drops of essence of rawhide or oil of hickory, indicating the need for whipping and punishment. And these were from physicians at the time. They were guilty of work ethic stereotypes and frequently lamented, and I quote, "It was a characteristic of their race." One physician at the time noted, slave owners, the responsibility of the doctors, they viewed it as their responsibility to the slave owners and less to the true health of the patients they were caring for. One of the facts I didn't realize was that many Southern physicians earned most of their annual income treating enslaved people. As medicine moved from house visits to hospitals and we pushed for more research and medical education, African Americans bore a disproportionate brunt of research and experimentation. One example is that over half of the articles in one of the major journals in 1836, half of them were experimentation on black people. In 1830, at the time, experimental C-sections done by one of the leading researchers at the time found that over 30 of the 37 experimental C-sections were being performed on enslaved people. And these experimentations and surgeries were not attempted on white patients until they were perfected on black patients often. One example famously, or infamously, is of Dr. Sims, viewed as the father of gynecological surgery. At one time was the president of the American Medical Association. He was known for mastering vesiculovaginal fistula repair. Over a period of 5 years, he repeatedly did surgeries on African Americans to perfect the technique, not using anesthesia. Only once the technique was perfected did he go to white patients and start using it, and obviously at that time used anesthesia. And this highlights a view of African Americans as feeling less pain, and that view has persisted to this day in some form or another. And this misconception persists, and we can see it in prescribing practices. A review of in 2012 meta-analysis looking at 20 years of data concluded that African Americans and Hispanic patients were much significantly less likely to receive pain control than their white counterparts. And one of the worrying aspects of it was that from year 1 to year 20, there really wasn't a difference, wasn't an improvement in how those pain control was prescribed. In 2007, Erlanger and UTC, or UT Chattanooga, actually participated in a survey study comparing patients' described pain versus the perceived pain by the provider, looking at what the patient said they felt versus what the provider looked at and evaluated and thought that they saw as a level of pain in those patients. And what they found was that physicians were twice as likely to underestimate pain in black patients compared to all other ethnicities combined. And as modernized medicine continued and evolved, research and education came to the forefront. Patient care shifted from house calls to hospitals, focusing more on medical education and formal medical schools. And what they came to need were clinical subjects for medical education. And these early schools were notorious for unnecessary surgeries and amputations. One example was a Georgia physician with his students who, after amputating the leg of a 15-year-old enslaved person with only minor injuries, he instructed his students the decision to amputate should be weighed differently according to the person's race or class. Medical schools relied heavily on African Americans as clinical subjects, and unfortunately that didn't even end at death, as they were often utilized post-mortem in the form of cadavers. Just down the road at Medical College of Georgia, they recently, in 1989, they went to evaluate a prior MCG building to excavate it and found in the basement over 10,000 human bones, over 75% of them African Americans, and these were from prior cadavers. And what they also found with a team from Georgia State evaluating this was that these bones had been used for experimentation from 1835 to 1912. And what we now know, after looking at posted memoirs and actual records and lectures from the porter who actually obtained the bodies, was that most of these cadavers were taken from a nearby black cemetery. As one source lamented, those treated unequally in life were also treated unequally in death. No talk about race can start without talking about Tuskegee. It's one that a lot of us have heard of, know a little bit about. I knew just a little bit about and knew the name and know what it conjures up when you say the name. But I think the detail is really where you get to start to see the sinister nature of it and how pervasive it was. Started in 1932. It was in Macon County, Alabama, an extremely poor area with minimal medical resources. It was actually, the study was initially put out by Booker T. Washington, the goal being increase medical care, foster economic development in the area. He had earmarked money specifically for syphilis treatment. Just think how differently things would have gone if that had been the case. Unfortunately, with the Great Depression, the study was put on hold, and that was until the U.S. Public Health Service saw an opportunity for experimentation and stepped in. The mentality of them can best be summed up by this quote of one of the lead physicians of the research. "The scourge sweeps among them. Those are treated are only half cured, and the effort to assimilate a complex civilization drives their diseased minds until the results are criminal records. Perhaps here, in conjunction with tuberculosis, will be the end of the black problem. Disease will accomplish what man cannot do." This trial started in 1932 by offering free medical care to the area. And these were people that had no and minimal medical access. Many of them, this was the first time they'd ever seen a physician. Patients were told they had bad blood, and they were treated with placebo. The Public Health Service saw an opportunity for experimentation and suggested that they save money by withholding the expense of any treatment and simply observing them. In the end, nearly 400 men with syphilis were selected, with the goal, after 1 year, quickly switching to bringing these cases to autopsy, as one put it. Another one put it this way: "As I see it, we have no further interest in these patients until they die." In 1943, after penicillin became common and treatment could be attainable, the U.S. Surgeon General, after being concerned that the research information would be lost, stated that the opportunity represented by the Tuskegee trial and these patients would never come again and must be exploited. Steps were taken to ensure collection of autopsies in overwhelming fashions in so many levels. They told a local nurse to befriend the patients, make sure they made it to their appointments. They convinced local doctors not to treat. They instructed military physicians to withhold treatment and submitted a list of participants to be exempt from the draft. And as these people died, autopsy results were obtained. They were published. They were presented at the American Medical Association conferences where other peers could review the data and evaluate it. And I think this is one of the most concerning aspects of the trial, was that this trial wasn't done in secret. It wasn't done in a bubble. It was presented. There was data. There was articles. And it was never stopped. No one ever said, this needs to stop. We can't continue on doing this. And that's one of the more concerning aspects of this trial. It only stopped in 1972 after an Associated Press article came out uncovering and publishing this study. Medically, one of the long-lasting legacies of this study is that we owe several tests to the fact that this study occurred. Several syphilis studies and blood work we have specifically because of the research done on these patients. Outside of medicine, the real aspect and impact of this study was on the people that were affected in their lives. By 1955, we already had evidence over a third of the patients had died directly from syphilis. 40 wives had been infected, and at least 19 children were born with defects who had no evidence or no one signed up for that study in these people. One of the major societal level impacts of this study was the effect on physician trust. Before I had this talk, I spoke to a good number of black friends and colleagues, mostly so I could avoid looking ridiculous and saying something silly. But what I had heard over and over again was, hey, make sure you talk about Tuskegee. Bring up Tuskegee. Because to them, it was a huge aspect of their view on healthcare. As an aside, none of these friends that I have, non-medical, many of them, had any plan to get the COVID vaccine anytime soon. And Tuskegee was a main reason why. These are physical therapists, auditors, IT engineers, businessmen, teachers, well-educated people refusing to take potential disease-preventing therapy due to these wounds of the past. One friend described it this way: my grandmother didn't trust physicians because of Tuskegee. She passed that thought on to my dad and myself. That's what I grew up in. That's what I grew up hearing about. So it explains why we've had so much trouble recruiting black patients to participate in the COVID vaccine trial. And as providers, we look at the vaccine trial and the early vaccination of black patients as a way to offer care to a high-risk population. But what they see are shadows of Tuskegee. Experimentation wrapped in empty promises of care. Trying out a vaccine on them before giving it to anyone else. In 2006, JAMA article reported that, and confirmed what most of us would have expected, that there are significantly lower levels of trust in the healthcare providers among black patients compared to whites. Now, the Tuskegee trial and its evaluations didn't stop there. One of the main trial researchers took this data and took this research style and brought it to another patient population in Guatemala. In Chattanooga, the Hispanic population in this area is very diverse, and Guatemalans represent one of the fastest growing Latino groups in our region. So it's disheartening to know that when they come to this country and they come into this area to deal with our healthcare system, that it's already tainted historically by what our country, what U.S. medical community and the public health service did. From 46 to 48, an NIH-funded experiment led by a researcher in the Tuskegee trial intentionally infecting over 5,000 Guatemalans with STDs without their knowledge, without their consent. After the study was concluded and a U.S. commission was formed to evaluate any potential ethical issues with this trial, what they concluded meekly was that they were a suitable experimentation population by virtue of their poverty, ethnicity, race, remoteness, and national status. The Guatemalan government put it in a different way, concluding that it to be a crime against humanity. And to this day, many have never received treatment. In 2010, Obama formally apologized for these atrocities. Evidence of unnecessary surgeries persisted into the 70s. Here's an article from the Boston Globe, in case you thought this was just a Southern issue, showing that in 72, front page, highlighting accusations made by medical students in the Boston area, accusing the Boston City Hospital of excessive and unnecessary surgeries. They reported that they saw Black and Latino women more often sterilized by hysterectomy, while white women were more often sterilized with less radical procedures. They accused the Boston City Hospital that these were explicitly for the purpose of training residents. What's frustrating is that this is exacerbated by the knowledge that Black women are more likely to undergo hysterectomies, despite that fact of this surgical sterilization, that they have longer hospitalizations, 3 times more likely to die. I don't know what's going on here. Yeah, are we still on? Because I have nothing on my screen. And this was exacerbated by the knowledge that the Black women were higher risk for complications, longer hospitalizations, and 3 times more likely to die during admission after a hysterectomy. So these surgical sterilizations, forced or without consent of marginalized communities, is deep roots in America. And in the South, the practice was so common that it was called a Mississippi appendectomy. If you think this is a remote phenomenon that has done, it's gone, we've never seen it before, all you have to do is look on the news of reports of migrant detention centers and the claims that these women in these migrant detention centers have undergone hysterectomies without consent there, to know that this is still an ongoing issue. And finally, a study in 1992 to 97 in Colombia conducted experiments to find links between genetics and violence. What they were looking for was a mean gene. And looking for that wasn't so much the issue, but how and where they looked for it. An example of this and how they looked for it, they only looked in Black and Latino boys. The study that was approved and the protocol approved by the IRB specifically excluded white boys in this trial. It was written in the initial protocol. And this is an example of scientific racism, the use of science to attempt to justify racist thought or views. You can make an argument about the validity of trying to find a gene potentially responsible for violence, but not if you're only going to be looking at it in one group of people. These children were given fenfluramine, part of the known cardiotoxic fen-phen, to induce elevated serotonin levels with the thought that that rise would indicate levels of violence. And that connection has since been disproven. These children were given experimental medication, not approved for kids in their age at the time, with no therapeutic benefit intended, only to prove finding a violent gene only in 1 or 2 races. Now, these represent just a fraction of the 244 years of examples of healthcare workers and the institutions perpetually not meeting the call to equitably provide for those that seek care in our hospitals and clinics. So you can imagine how this can erode the trust of physicians and healthcare systems in the collective psyche of a community of color. I don't know what that's like. It's not been my journey. But as a provider, I think that by learning about this history, we can better approach the situation with an empathetic ear and work to improve our care to these communities. Looking at the patient-physician relationship, we know that Black and Latino patients have worse healthcare outcomes, shorter lifespans, and than many other races. And due to that, in part, is because of a health pattern, a historical pattern of abuse by the medical community. They have higher levels of distrust in healthcare providers, particularly in the African American population. Distrust is really vague. Distrust doesn't describe a lot of things. So how can you convert that into something more tangible? One study looked at its effect and looked at distrust on recommendations for routine medical care instructed by the physician and who actually followed up on those instructions. They followed, and they found that among Black men, those that reported higher distrust of physicians were more likely to delay routine health care, blood pressure checks, cholesterol checks. Now, race itself, in one other study, didn't, and when looking at delaying of prescription pickups, race didn't affect the likelihood of delaying the pickups, but what did was the perception of discrimination from the physicians. The people more concerned and more suspicious that there was discrimination were less likely to pick up those prescriptions. In the HIV/AIDS population, already stigmatized by the diagnosis. One study found that the patients reporting feeling discrimination were less adherent to the medications they were given. And at this point, you can probably look at it, and say, I really think a lot of stuff bad happened in the past. That's awful. That's horrible. I hate it. I know I'm not racist. Couldn't it all just be socioeconomic factors, the discrepancies that cause discrepancies in healthcare outcomes, adherence, and other health measures? And it just happens that Black and Hispanic patients are more likely to be in those lower socioeconomic levels, and it's just a correlation and not causation. Is there any way to look at that? 2016, it is true, obviously. Chattanooga Times Free Press reported in 2016 that in Hamilton County, the average white household earns about $56,000 a year, while Hispanic and Black households earned about $37,000 to $29,000 on average. So it's true there's differences in household incomes. A group of researchers tried to see if there's a pattern that they could decipher and take out race from other confounding factors. And they looked in the VA system, where it wouldn't matter if the patient could or could not pay, covered in the VA system. And they looked at over 400,000 admissions for cardiac diagnoses and looked at who underwent stenting, angioplasty, and CABG among those patients. What they found after taking out confounding factors such as age, sex, where they were located, income, they found that consistently Black patients underwent fewer cardiac procedures. Nearly twice the rate of catheterizations, 3 times the rate of angioplasties, and over 3 times the rate of CABGs were done on white patients versus Black patients. And these were done by salaried physicians in a VA system where financial incentives are minimized for procedure, and you typically aren't concerned about what the patient can or cannot pay, effectively trying to take out those confounding factors. And what you're only left with is race. You can't directly attach causality here as a retrospective review. Is this implicit bias in the providers statistically offering procedures less frequently to Black patients? Or is this a reflection of the higher likelihood of distrust among Black patients, causing them to delay or defer these procedures? Or is it low adherence in the setting of distrust? It's unclear, but what we know is that a 3-to-1 difference in the rate of indicated cardiac procedures is a missed opportunity to close the gap of healthcare equity. This was followed up in 2002. American College of Cardiology and the Kaiser Foundation put out the weight of the evidence in the cardiology world. They looked at over 81 studies, and what they found was in the 68 of those 81 studies, there were differences in care provided to the patients based on race for at least one minority group in those studies. And this is in the setting of taking out confounding factors: health, heart disease, comorbidities, insurance, sex, age. Black patients still underwent fewer indicated procedures. What they concluded was this review provides credible evidence that African Americans are less likely than white Americans to receive diagnostic procedures, revascularization procedures, thrombolytic therapy, even when patient characteristics are similar. This is not just a cardiology issue. Mass General Surgical Department reviewed over 215,000 patients who had received intervention for peripheral vascular disease, evaluating who underwent amputations versus salvage procedures such as angioplasty or stent placement. What they found was that there was a huge discrepancy in amputation rates. 42% of the Black patients in the study had undergone an amputation, while only 28% of the white patients had. And that discrepancy remained when you took out confounding factors, disease severity, hospital types, demographics. The difference remained when they looked the same. One of the interesting aspects of this was one of the factors they saw that started to narrow the gap and to decrease the disparity in the amputations was the diversity of the surgeon's patient population, meaning that the Black and white patient amputation rates were more similar if the surgeon took care of a more diverse group of people, if he had more frequently come across people that didn't look like him, and that was normalized. So have we improved? Have we gotten better from where we have been? In 1985, the Heckler Report came out, and it was one of the first studies looking at minority health in this country. And while it was limited, it looked at the differing minority groups in America. What it found was that it didn't have enough data. It looked at Hispanic patients, it looked at Native Americans or Asian Americans, and it didn't have enough data on those patient populations. It did have some data on African Americans at the time and found that the health disparities in that population were driven mainly by 6 conditions: cancer, heart disease, diabetes, infant mortality, cirrhosis, and homicide and accidents. Those 6 combined accounted for 86% of the excess black mortality compared to white patients. One of the main takeaways from the report was what it lacked, not what it had, but what it lacked, is that it didn't have data. We weren't good at the time of collecting data on race and comparing it to outcomes. And this report, the Heckler report, was credited for being able to push for this increased data and to have a better idea of where we stand and how it affects care and outcomes in this country. Unfortunately, this really wasn't followed up in any major way until 2003 with the unequal treatment report put out by the Institute of Medicine. What it did was look at over 600 articles addressing racial disparities, and for the first time really introduced the role of bias as a contributor to disparities. And this notion that, I might set out to care for all my patients equally, regardless of what they look like and their ethnicity. However, either explicitly, subconsciously, we're treating certain groups differently. That's what we're seeing potentially in these evidence from the VA cardiology study, from the Mass Gen Amputation Review. When all the factors are removed, as well as you can, what we're left with is patient race. And that factor is still affecting healthcare outcomes. And black and brown patients are getting different and likely inferior care for some reason, and bias probably plays a role. Here they tried to illustrate exactly where and how it comes into play. It's a little odd illustration, but I hope it helps. On the left here you see quality of healthcare, with non-minority care vastly surpassing minority care, with an illustrated difference. And the illustrated difference shows that it's made up of probably 3 parts. First part is one that's likely expected. You have clinical appropriateness, need, patient preference, potentially deference of procedures. And the other 2 is what they're calling disparity at the individual and at the institutional level. At the institutional level, you see the operation of healthcare systems and legal and regulatory climate, as they call it, but what you can also call it is institutional racism and difference. At the individual level, you're seeing discrimination, biases, stereotyping, and uncertainty, as they're calling it. And I think uncertainty is really a word that should be emphasized here, because as they look at it, they feel that uncertainty is where most of this is occurring. Most of these implicit biases are occurring in the areas of uncertainty, in gray areas, when you stop having clinical evidence-based medicine to follow and you're more at your discretion to treat. That's when your implicit bias takes over and what you think is indicated for that patient versus not. And your implicit bias might drive that you give different care to different people. So how do we improve? How do we make this better? The Institute of Medicine report concluded that it's obviously a complex problem requiring multifaceted response. It requires practice changes at every single level, at the provider level, at the patient level, at the payers, health plan purchasers, and society as a whole. Every single person has to contribute. At the healthcare system level, they emphasized evidence-based healthcare delivery to minimize uncertainty, wanting resources allocated based on public clinical guidelines, trying to minimize the gray area. They recommended restructuring physician financial incentives, as currently it's disproportionately restricting minority patient access to healthcare. They wanted and recommended shifting from a productivity-based to incentivizing clinical benchmarks, incentivizing patient improvements in provider-patient communication, trust, preventive care, and screening and evidence-based care. They also recommended enhancing interpretation services in non-native English-speaking communities, bridging cultural barriers where they exist, and working to improve healthcare plan coverage gaps as they disproportionately affect patients and people of color. They recommended to increase historically underrepresented minorities among the healthcare professionals. We know that while African Americans represent 12% of the population, they only make up 4% of physicians. And we know that black patients in particular report higher levels of physician distrust. One key found to be able to improve physician trust was to have a race-matched physician. Increasing representation in medicine. They found that patients paired with the same race physician receive 34% more preventative care. That's 34% more vaccinations, pap smears, colonoscopies, or mammograms. And a lot of that can be due to improved communication, improved trust. An exercise to do to put yourself in their shoes is, imagine that not a single doctor you see looks like you. Not a single doctor that you see goes to the same church as you go to, does the same things, and may not have the same lived experiences as you. Do you think you trust them as well as if they did? And I think it's a good exercise just to put yourself in a minority patient's shoes when trying to evaluate this situation and how it might be benefited if we were able to change it. On a patient level, on the healthcare system level, they recommended improving access to primary care, limiting ER visits for non-urgent care, and building rapport, trust, and longitudinal care, and increasing the use of community health workers, and strengthening multidisciplinary and preventative care teams. The same study that found that African American patients had lower trust in physicians, and they noted that one of the key contributors was where they actually interacted with doctors. Is it seeing your doctor in a clinic, or is it engaging in doctors in an urgent care or an emergency setting? And that decreased reported levels of physician distrust. Seeing patients in their clinic, seeing primary care doctors, and having a rapport and building that longitudinally improves care. It's not an earth-shattering concept, but it's proven that it helps improve communication and trust. We also, and this is one of the more difficult ones, we need to collect more data on race and ethnical disparities in healthcare and ongoing research, allowing to monitor and for monitoring performance, accountability, and identifying discriminatory practices. And the goal of this should be education. It should not be punishment. It should not be punitive. Because as we stand up until 85, we didn't have any data. Now we have better data, but we still can use more to better understand where the discrepancies lie and how to improve those. And I know the implication of this. In an ideal world, we would have hospital and provider level data to evaluate care disparities, to monitor better. This is obviously a sticky recommendation. Red flags would go up in most providers' minds to the implications of this. And I get it, no one wants to be near this label. And before we even did this, we would obviously need to unpack a lot on the topic as a community before safely being able to do this in a safe place where it's not punitive. But for patient care, this could improve outcomes as well as trust. Because whether we acknowledge it or not, the data says we as a whole are treating our patients differently. So we need to destigmatize the conversation around implicit, unconscious bias so that we can have this conversation. Not to identify, vilify, or ridicule. Education is the key. Because we aren't describing horrible, hateful physicians here. Implicit bias is a ubiquitous cultural phenomenon. It affects us without our knowledge, and no one is immune. On the provider level as well, on continuation, this is where we really have to focus on as a provider, and the emphasis of most of the study was on tackling the provider biases. Because what became clear is that we unconsciously treat our minority patients differently. Not every time, not intentionally, but on average, we're providing them different care. Not offering the same indicated procedures, under-recognizing pain. And what is needed is creating stronger bonds of trust to maximize chance for treatment adherence. This Institute of Medicine report and over the 600 articles it reviewed points to our implicit bias as part of that problem. We also need to improve cultural competence through cross-cultural curriculum, integrate that at every single level, starting in the medical school. This isn't something that is built in the medical school. It's not something that is taught. It is something that every single person brings into it. As opportunities to improve bias, this is where we have to start. They also recommend practical case-based training for active practitioners at all levels. Because the implicit bias is hardwired in all of us. In 2011, they looked at first-year medical students at Johns Hopkins. And what they found was, looking at implicit association testing, the majority of them, first year, had scores consistent with a strong preference for white people. An additional study with similar results evaluated pediatric faculty in Pennsylvania and found that when they were tested, they too had scores consistently with preferences for white people. And these were faculty members included in this testing were ones that mentored students, recruited medical school candidates, and were in leadership roles. So you can start to see, as these people in positions to recruit, to build, have an evidence of bias, and they start to act on those bias and those subconsciously favoring one race over another, and start to recruit white patients or white students, hiring white faculty with a similar biases, likely that cycle can continue, perpetuate, and ultimately form what institutional racism, unintentionally, but it's still there. In 244 years, medicine has evolved tremendously in this country. We've moved from bloodletting and arsenic to immunotherapies and molecular receptor level treatments. But in racism, as in cancer, we've made great advances, but have yet to achieve true eradication. That, however, should not deter us from continually pushing the needle in both respects. While truly sinister, explicitly racist acts on the part of the providers is mostly a thing of the past, the remnants of that history live on through our unconscious bias and its contribution to healthcare inequities in our patients. My hope for talking about this was just to shed light on this topic, to allow a forum and ability to start that conversation. It's an intimidating topic, and hopefully diminishing the stigma associated with it, because our goal is always here is for self-improvement as providers, as well as ultimately leading to better outcomes for our patients. And finally, what we need to do is normalize acknowledging that race exists as a social construct. Acknowledging its existence is less a biological truth that genetically determines health, but rather a determinant of health due to society, due to the meaning ascribed to it societally, and therefore viewing its effect not so much as a predetermined health indicator, but in fact a malleable social factor able to be destigmatized in our efforts towards better, equitable healthcare. Do you remember the gardener? Her preference for red flowers over pink flowers? She never fixed the soil. As part of an institution in healthcare that contributes to racism, we have to do our part to fix the soil, work to eliminate our subconscious biases in patient care, support institutional level changes that can add nutrients to the soil in areas most in need of it. Because when that happens, and the pink flowers flourish to the level of red flowers, the original gardener may always hold in her mind her preference for pink flowers, but after the soils are equal, and over years, the resulting flower beds now grow the same height year after year, her children and their children will grow up having never known a pink flower to be any different than a red one, and thus less likely to perpetuate their mother's preference for red over pink. So my hope in reviewing this topic, obviously, is to lead to an increased awareness, allowing a space for a tough but necessary conversation, as well as self-reflection on your practice, as well as mine, and being keen to notice hidden biases that we might have. Because I know looking into this topic and reviewing it as a new topic for me has certainly opened my eyes to things that I need to change, and I hope it has for you as well. Thank you, and I appreciate your time. Do we have any questions?
Eric, this is Mukta.
Do you unmute? Any questions? Do I win?